Thank you very much. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ربي اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. As you all know, today the topic of presentation is acute exacerbation of COPD and its management. COPD is a very common disease throughout the world, and it is fourth leading cause of death nowadays, and maybe third leading of cause of death by 2025. It's a progressive obstructive airway disease where the airway obstruction is most of the time is irreversible, and the most common cause for COPD is cigarette smoking. And during the course of COPD, if the patient is taking his medicine, it is punctuated by periods of acute worsening of respiratory symptoms, which is known as acute exacerbations of COPD. And many of the patients who take their medicines regularly, even they suffer from acute exacerbations. Means, in spite of taking medicines, there are many reasons which worsen them and is labeled as acute exacerbation. And acute exacerbation of COPD is regarded as symptoms that require additional therapy. AE-COPD are complex events usually associated with increased airway inflammation. Whenever there is exacerbation, it will lead to increased airway inflammation. There is more mucus production. There is gas trapping. Patient becomes more dyspneic, and there is lot of sputum which is purulent and increased in volume, and there is increased in cough and wheeze. AECOBD can be precipitated by several factors. The most common cause are respiratory tract infections. There are many causes of acute exacerbations, maybe non-infectious and infectious. And in infectious, there may be many other causes, but the bacterial infections are the most common cause of acute exacerbation of COPD. The other triggers include environmental pollutants. There may be pleural effusion. There may be triggering of the other factors like heart disease worsening. There may be, pneumothorax on top of COPD. They can all lead to worsening of the symptoms of COPD, and patient may present with acute exacerbation of COPD. Along with community-acquired pneumonia and acute exacerbation COPD, they are the most common, important bacterial lower respiratory tract infections. You all know this. Now we'll come to the etiology of acute exacerbation of COPD. As I have told you, 20% of the cases are non-infectious. In this, there may be certain environmental factors, and one of the common cause of acute exacerbation is non-adherence to the medications. And while 80% cases are due to the infections, and in infections, most common are bacterial infection. 40 to 60% cases of infections are due to bacterial infections, and there may be 30% cases due to viral infections, and there are atypical bacteria leading to the acute exacerbation is in 5 to 10%, like chlamydia, pneumonia, and other atypical organisms can also lead to development of acute exacerbation of all. And in most of the cases, if we do the sputum culture examination, the most common organisms which are isolated for the acute exacerbation of COPD are bacterial causes. And you show to show what are the common bacterial pathogens which cause acute exacerbations. As you all know, this is Haemophilus influenzae, Moxarella catarrhalis, and Streptococcus pneumoniae, in addition to other bacteria. But these three bacteria are very common in causing acute exacerbation of bacterial infection. Viral infection may be predisposed to patients with bacterial. If any patient has viral infection, there may be a superadded bacterial infection in all of these cases. Specific bacteria isolated depend on factors such as age of the patient. If patient is older, the gram-negative organisms are more common. Then steroid use, comorbid illness such as cardiac disease, structural lung disease, or more severe COPD. The bacterial flora depends upon these few points as well. Some studies indicate that more resistant organisms such as Klebsiella pneumonia, Staphylococcus aureus, Pseudomonas aeruginosa, Escherichia coli, and Acinetobacter and Enterobacter species are increasingly being seen. particularly in developing countries. So you can see, apart from Moraxella catarrhalis, Streptococcus pneumoniae, and other, H. influenzae, these are the common organisms which can be found, like Pseudomonas aeruginosa, Escherichia coli. They are very common in exacerbation of COPD. And we must know what are the consequences of acute exacerbation of COPD. As I have told you, every time patient gets exacerbation, there is, decline in the lung function, worsening quality of life. There is more hospitalization, more expenditure, more expenses are, on hospitalization. There is increased risk of mortality, and there is lot of economic burden. Patients underreport usually acute exacerbations of COPD, and delay in diagnosis can lead to increase in the mortality. Even a single exacerbation episode will lead to prolonged negative effect on health status of the patient. This slide shows you decline in lung function. If the exacerbations per year are less than 1.5, then the lung function decreases at 2.53 ml per year. And if exacerbations are more than 1, 2, or 3, then the lung functions decrease more rapidly, and the lung functions, decrease at the rate of 46 ml per year. So there is this p-value is very significant. So as the patient has more exacerbation, the decline in lung function is more. So we have to control the exacerbations of the COPD. And again, if we see the mortality of the patient, this slide shows you, as the number of exacerbations are increased, if the exacerbations are more than 3, the mortality is also very high in these cases. So we have to cut down the exacerbations. How to manage COPD? There are many guidelines which recommend different drugs for the use of in exacerbations. And before I go to the management, classification of COPD exacerbation may be divided into mild, and these patients are treated with short-acting bronchodilators only. But if patients comes with moderate exacerbation, then of course, along with short-acting bronchodilators, we have to add antibiotics depending upon what type of antibiotic has to be given, oral or injectable. And along with these, short-acting bronchodilators or antibiotics, we have to add the short rescue course of corticosteroids. While if a patient presents with severe COPD, then the patient definitely required, hospital as admission. How to divide the 3 classes of medication recommended for COPD exacerbations are mainly bronchodilators. The mainstay of treatment for COPD is bronchodilators, either short-acting or long-acting. But in cases of exacerbation, we usually use short-acting bronchodilators. Systemic corticosteroids can improve lung function, oxygenation, and shorten recovery time and length of stay in the hospital. Can be given for about 5 to 7 days. Antibiotics will also, shorten the stay of hospital, and they will improve the recovery time, reduce the risk of early relapse and treatment failure, and the duration for the treatment of antibiotics in acute exacerbation is again for 5 to 7 days. The use of antibiotics in the treatment of acute exacerbation has been controversial previously, but many systemic reviews have shown that if the patient is presenting with acute exacerbation, the most common cause is the bacterial infections, and the use of antibiotics reduce the risk of short-term mortality by 77%, treatment failure by 53%, and sputum purulence by 44%. And these data are supported by many recent randomized controlled trials. Then principles of appropriate antimicrobial resistance has to be stopped, and there is antibiotic stewardship. Bacterial infection, where you suspect there is bacterial infection, then only the antibiotics are required. In patients with acute exacerbation who do not present with bacterial infections, you should not prescribe antibiotics. And you have to optimize the diagnosis, and the severity of assessment has to be assessed. Then patient should be managed according to the severity of the disease. Then maximize eradication of bacterial pathogens, if any. Recognize local resistance prevalence. The data is available in every country, every local area, even every hospital in developed countries, but we are lacking in this. we must develop some, biogram, antibiogram to prescribe antibiotics according to the, prevalence of the bacterial pathogens in the local community. Then PK, PD to choose most effective agents and dose, local resistance, efficacy, and maximize cost effectiveness empirically but intelligently. Then encourage patient compliance. There is a triangle which is called Anthosonian criteria or triangle, which shows a patient is suffering from acute exacerbation of the COPD. We have three symptoms: dyspnea, sputum prolens, and sputum volume. If patient is already on his treatment and there is sudden increase of dyspnea or sputum prolens or sputum volume, we can safely say the patient is suffering from acute exacerbation of COPD, and we have to treat patient accordingly. As I have shown you that the most common organisms are H. influenzae, Moraxella catarrhellus, and Streptococcus pneumoniae. So recommendations and published evidence suggest a broad spectrum antibiotic, maybe amoxicillin, clavulanic acid, macrolide, second and third generation cephalosporin, depending upon the availability of the drug. So these are the drugs which can be given if you suspect a bacterial infection, and these common three organisms are usually covered by these organisms. European Respiratory Society and American Thoracic Society guidelines in 2017 state that in ambulatory patients with AECOPD, antibiotic selection should be based upon local sensitivity pattern. This is very important. These are the guidelines which recommend, the use of antibiotics in acute exacerbations of COPD, but in only those cases in which we suspect bacterial infection, not in all cases. But of course, in 80% of the patients, we have bacterial or viral infections. So we have to use mostly antibiotic in acute exacerbation of the COPD along with steroids and bronchodilators. So these are the common guidelines. Gold guidelines, which is the commonest global initiative for lung disease, which is mostly being followed in all over the world, and we've also followed these guidelines. And these are other guidelines which show the use of antibiotics in acute exacerbation of the COPD. According to the gold guidelines, even in 2021, the latest guidelines which have been issued in 2021, and they show antibiotics should be given to patients who have the three cardinal symptoms: increase in dyspnea, sputum volume, and sputum prolens. So you have to take the history of the patient. If there is increase in the prolens mean the color of the sputum. If it is yellowish to greenish, then you must think the bacterial infection. If there is increase in the sputum volume, you must think of bacterial infection. And there is increased dyspnea, you must think of acute exacerbation of COPD. And if any of the two are present, then we take this is a severe, exacerbation of COPD. And in these cases, the length of therapy for antibiotics is 5 to 7 days. Choice of antibiotics based on local resistance pattern. Usually initial treatment is aminopenicillin with clavulanic acid, like amoxicillin, clavulanic acid, macrolide, and tetracycline. You may choose any of the antibiotics from these three, but most commonly amoxicillin, clavulanic acid is, I think, is most appropriate in these patients. And according to the NICE guidelines, consider an antibiotic for people with an AECOPD, but only after taking into account symptom severity, particularly sputum color change and increase in volume or thickness beyond the person's normal day-to-day variation. Means you have to properly assess the patient for acute exacerbation, and you have to suspect the bacterial infection as well. If you suspect bacterial infection, only then you have to give antibiotics accordingly. And whether hospitalization is needed or not, previous exacerbation and hospital admission history and risk of developing complications, previous sputum culture and susceptibility report is very important, because at the time if patients comes to you with exacerbation, you must ask and try to see if there is any previous report of sputum culture, and you can choose according to that culture report. Or आपने according to antimicrobial resistance risk with repeated course of antibiotics. NICE guidelines recommend first choice of oral antibiotics is again, according to the sputum culture and susceptibilities. But when the patient presents you with acute exacerbations, you don't have immediately the culture and sensitivity report. You send the sputum of the patient, and you may start with amoxicillin, clavulinate, doxycycline, and clarithromycin. But if the second choice, if patient is not improving with these drugs, so you may use alternate drug like levofloxacin and cotrimoxazole. Sanford guidelines to 2018 studies show the value of antimicrotherapy in severe disease. So all the guidelines suggest the use of antibiotics in acute exacerbations of COPD. For severe disease, amoxicillin, clavulinate, or azithromycin plus or clarithromycin or oral cephalosporins can be used. For mild to moderate disease, no antibiotic or only amoxicillin or doxycycline, not cotrimoxazole or cephalosporin can be used. WHO recommends as first choice of antibiotic in cases of acute exacerbations is amoxicillin clavulinate, and if this is not available or patient does not improve with this, then you can use doxycycline and cephalexin. For ambulatory patients having a COPD exacerbation, administration of antibiotics is also suggested according to European Respiratory Society and American Thoracic Society guidelines, because most of the patients do have bacterial superadded infection. If we will not cover with antibiotics, so exacerbation of COPD is not going to relieve. Antibiotic selection should be based upon local sensitivity pattern. Episodes that present with purulent sputum are most likely to benefit from antibiotic treatment. However, there may be other consideration, that is disease severity, when deciding whether or not to prescribe an antibiotic. AAFP guidelines, these are old guidelines, 2010, but again, these again recommend the use of antibiotics in exacerbation of COPD, particularly when you are suspecting bacterial infections. Okay, with this, I think I have finished my talk on acute exacerbation of, but taking the advantage of, your presence, all of present nowadays, the most important problem going on is, common is COVID-19. So only two or three things I would like to share with you. In cases of COPD, if patient gets COPD and COVID also, so you have to continue with the regular treatment of the COPD. But along with this COPD regular treatment, we must be treating patient on the lines of COVID management. Follow basic infection control measures, wear a face covering, consider shielding, and only essential spirometry if it is essential. Necessarily, we should not do spirometry in every case of COPD and COVID-19. Ensure adequate supplies of medication. Continue unchanged, including inhaled corticosteroid. Every patient should continue with his inhaled corticosteroids and other treatment. It should not vary. Ensure annual influenza vaccination and maintain physical activity. In case of severe COPD and COVID, patient should be admitted, and according to the guidelines of COPD and COVID-19, patient should be treated accordingly. But the most important thing I would like to say is about the vaccination. All patients of COPD, stable COPD, should get vaccination of COVID-19. Even I will say every patient of respiratory disease who is stable, even ILD, even bronchial asthma, they should get their vaccination, and they should get 2 doses of vaccination which are available in Pakistan. So with this, I would like to finish my talk. Thank you very much. If there are any questions, I am most happy to take them. Thank you very much.
Thank you, Dr. Khalid. It was a great and very engaging session from your side. I hope that most of our attendees will take the opportunity from the knowledge they have gained from your talk. But meanwhile, the so how really we can make this
Okay.
differentiation?
The most important thing in acute exacerbation of COPD is the symptoms of the patient. If patient presents to you, as I have shown you, Anthosonian triangle, which or criteria which shows if there is an increased in the quantity of the sputum or increase in the purulence of the sputum, this usually means the patient is having, the bacterial infection. Patient is presenting with fever. Patient is presenting with acute dyspnea and worsening of the quantity of the sputum. If any of the three is present, this is called severe acute exacerbation of COPD. If two are present, it is moderate. If only one is present out of these, this is called mild acute exacerbation of COPD. But in moderate and severe COPD, as I have told, most of the time the acute exacerbation of COPD is due to the infection. And in the infection, most common cause is bacterial infection. So I think if the patient is taking already his medicines, or he is not taking his medicine and presents to the hospital with acute exacerbation, so we must take him as a bacterial infection, and we must start antibiotic on these patients for a short course, 5 to 7 days only.
Thank you, Dr. Khalid. Very well highlighted that we should consider looking at the patient history and antonism criteria, which is really important while it's we are looking at the patient and making the differential diagnosis. Second, very frequently asked question that sir we receive is that, for example, when we look at all these guidelines, they are recommending number of generations of antibiotics. Either we start with amoxicillin, clavulanate, or amoxicillin, or cephalosporins and macrolides and fluoroquinolones, and especially during these unprecedented times where most of our antibiotics were used even for the viral infections as well. What is, in your opinion, could be the better choice looking at the AMR rates across the globe as well? That how we should start our management plan for these patients?
The most important thing is to see, antimicrobial resistance, and antibiotic stewardship is very important. We must all consider this fact in our mind, because as we use lot of antibiotics, common antibiotics in COPD exacerbations and in other diseases, a lot of resistance are being developed. So we have to be very choosy about, the antibiotics. First of all, we must decide if patient require antibiotics or not. If as just tell you, if you suspect high suspicion of having bacterial infection, and patient is also bringing his previous culture sensitivity report, so I will suggest that we should start only with, very simple antibiotics, like which is commonly available as well, amoxicillin clavulanic acid combination, because which is commonly available, and it's very effective as well. But if of course patient has some allergy to this drug, or patient is not improving for 3 to 4 days after this, then we can choose a second line drug, maybe levofloxacin, moxifloxacin, or other antibiotics. But we have to be very particular in starting antibiotics in this case. But if patient is having severe, exacerbation of COPD, and he requires hospital infection, he requires hospital, then we should think of, injectable antics along with bronchodilator and along with steroid. But if patient is able to take orally, then of course we should start with oral antibiotics and oral steroids only. जी.
थैंक यू डॉक्टर खालिद। आई थिंक कि आपने बहुत अच्छे तरीके से हमें ये सारी चीज़ बता दी है कि हमें किस तरह से एंटीबायोटिक, स्पेशली जब हम बात करते हैं ACOPD की, then how we should start our antibiotic regime, keeping in mind that how AMR is increasing these days. And as you specifically mentioned that we need to look at our antibiotic stewardship program. So I would just like to add one point here, that from the GSK perspective and from coming from the medical department as well, we are highly working towards this antibiotic stewardship. And since 18 years, we have been collecting the isolates of strep pneumo and H influenza, and creating a data for the community acquired respiratory tract infections, because we know how important antibiotics is when it comes to the medicine side, not only the medicine side, but also the surgical side. And very well mentioned that we need to look at those susceptibility data, that how really are pathogens over here in Pakistan working against the recommended drugs. So thank you so much, sir, for highlighting the point that we need to keep in regards that how AMR is increasing during these unprecedented times, and we need to start with our first line treatment options rather than hopping towards the higher generation antibiotics, especially when it comes to the acute infections. So thank you so much, sir, for highlighting all points. But before we end this session, I would like to request you to please give us some take home messages before and your concluding remarks.
Okay, thank you very much. Take home message about, today's presentation is you have to be very particular about the antibiotic selection, and we should not use unrequired antibiotics, which is very common practice in, particularly in Pakistan. So by using unrequired, needed antibiotics, we are producing lot of antibiotic resistance, and this will be going to Khudana Khasta play a problem for our patients. As you have shown, we have to follow the antibiotic stewardship. We must prescribe antibiotics according to the culture and sensitivity report. But if you don't have culture sensitivity report, then according to the guidelines, we must follow the guidelines and prescribe antibiotics only where we require the use of antibiotics and where you strongly suspect the superadded infection with bacteria. The points have been mentioned, and you have to take detailed history. Then only can you can prescribe antibiotics. And the second message, which is very important, is about the vaccination of the COPD. I would request all of you to get vaccination and get your family member vaccination to stop the chain of infection. This is the only, I think, way, apart from other SOPs like wearing the mask, hand sanitization, keeping distance, not going to the crowded, keeping the ill patients at home or in the hospital. The most important thing which we are now getting is vaccination. अल्लाह करे कि हमारे मुल्क में ये वैक्सीनेशन और आ जाए, जो कि गवर्नमेंट इज ट्राइंग टू गेट इट मोर. So most of the population should be vaccinated to stop the chain of transmission. और my prayers, अल्लाह करे कि हम इसको जल्दी से जल्दी कंट्रोल करने में कामयाब हो जाए. As you all know, nowadays the peak is very rising. Still we have not achieved the plateau. It's still rising and deaths are rising. The only way would be to get vaccination, inshallah. Thank you very much.